Eu vou ter a honra de mediar essa apresentação e apresentá-los ao professor Stewart Tepper. O professor Stewart Tepper é professor de neurologia da Escola de Medicina Geisel, em Dartmouth, diretor do Centro de Cefaleias de Dartmouth, membro do board e diretor da American Migraine Foundation e da American Headache Society. Autor de diversos trabalhos sobre cefaleia em Salvas, com muita experiência, especialmente em casos difíceis, refratários, que são vários assuntos relacionados às suas publicações. Hi, Professor. How are you? It's a pleasure for me to be here in this meeting and have the opportunity to welcome and introduce you, like I said before. It's a great honor to listen about your experience in cluster, especially in galcanezumab in episodic cluster headache. You may begin your presentation, and after that, we will open to the audience for questions, okay? Thank you very much for your time with us. You may begin.
Thank you for having invited me, and I wish I were in Brazil for this presentation, and I'm very honored to have been asked. I want to talk about what is new in science and practical clinical management in cluster headache. These are my disclosures. I work with anyone in industry who is interested in creating new therapies for headache, so please bear that in mind. Specifically, the following disclosures are with industry developing therapies for cluster headache, including working in research and working as a consultant. Cluster headache is one of the most disabling neurological conditions. Patients are often disabled from work and from activities, and in the past have had difficulty tolerating preventive therapies, none of which was specific for cluster. But this is a very exciting time for the treatment of cluster headache. New therapies are transforming cluster headache treatment, and we now have the first medication designed for prevention of cluster and which is very effective in preventing episodic cluster headache. And I will talk to you about this. First, I thought it would be useful to present a case of mine, and he is very typical. A 35-year-old man with a 20-pack-year history of cigarette smoking. Excuse me, he is 45. And at 38 years old, in the month of March, he developed headaches that occurred daily, 1 to 3 times per day, for 2 to 3 months during which he had these daily headaches. And then the headaches went away for 1 year and then came back in March of the next year and every year thereafter to now. The headaches are always on the same side, around and above the eye. They can differ on which side from one cycle of headaches to another, but within the cycle, they stay on one side, side locked. Each headache lasts about an hour, is extremely severe in intensity, and occurs often at the same times of day, 11 in the morning, 2 in the afternoon, and 1 in the early morning hours, with the nocturnal attack awakening him from sleep. And that disturbed sleep adds to the severity of his disability. On the side of the headache, he has ptosis, a red eye, lacrimation, and rhinorrhea during each headache attack. He is intensely agitated during the attacks, rocking and pacing, and that is so different from migraine. He is unable to work during his daytime attacks. And as I said, his sleep is increasingly disturbed. His neurological exam was completely normal. He had an MRI with and without contrast, was completely normal. He was treated with verapamil up to fairly high doses. It failed to stop the headaches. He is severely disabled and desperate. He meets the International Classification of Headache Disorders, 3rd edition, the ICHD-3 criteria for episodic cluster headache. These criteria require a patient to have had at least 5 attacks. The attacks are severe or very severe. His were very severe. Unilateral, his are locked. Orbital and supraorbital or temporal, his were orbital and supraorbital, lasting 15 minutes to 3 hours if untreated, and his attacks each lasted 1 hour. In addition, the headache must be accompanied by at least one of the cranial autonomic symptoms or the sense of restlessness or agitation. And these cranial autonomic symptoms include ipsilateral conjunctival injection and or lacrimation. He had both. Ipsilateral nasal congestion and or rhinorrhea. He had rhinorrhea. Ipsilateral eyelid edema, forehead and facial sweating, meiosis and or ptosis, that is a partial Horner's. And of course, he had the sense of intense restlessness or agitation. Attacks have a frequency from 1 every other day to 8 a day. His were about 3 per day. And his MRI and neurologic exam and repeated cycles of cluster headache mean that this could not be attributed to another disorder. In the ICHD-3, there's a little differentiation from previous classifications. Episodic cluster now requires pain-free remission periods of at least 3 months per year, while in chronic cluster, there are no pain-free periods lasting at least 3 months per year. Clearly, he had episodic cluster, and there are differences in treatment for episodic and chronic cluster, which I will talk about. Let's begin with some pathophysiology and functional imaging. The cluster generator is in the ipsilateral posterior hypothalamus, seen on the right in functional imaging done by Arna Mai and Peter Goadsby. When the posterior hypothalamus is activated on the same side, it turns on efferent pathways that go through the superior salivatory nucleus and then on to the sphenopalatine ganglion, where postganglionic parasympathetics go out to the target organ, resulting in most of the cranial autonomic symptoms seen with cluster headache. So we have the overall anatomy down fairly clearly. But there is also a relationship in cluster headache to calcitonin gene-related peptide, or CGRP. And it is here that the differences between episodic and chronic cluster headache become more evident. In a study by the Copenhagen Headache Center, 37 cluster patients agreed to receive intravenous CGRP or placebo. In the episodic cluster headache patients, when they were in the active phase or cycle, 8 out of 9 developed a cluster headache attack within 70 minutes of the intravenous CGRP, while only 1 out of 9 with placebo. However, in the remission phase, none developed a cluster headache attack after IV CGRP or placebo. Our patient would then have been active and would have likely precipitated an attack with intravenous CGRP. In chronic cluster headache, where patients have cluster attacks every day and do not have a remission period, only half of these patients developed an attack after IV CGRP within 1 hour. None developed an attack after IV placebo. The chronic cluster patients then appear to be less susceptible to the effects of CGRP, and it may not play as big a role. Neurons in the trigeminal ganglia and the sphenopalatine ganglia express CGRP, and I showed you how the sphenopalatine ganglion is involved in the outflow for cluster headache. Interestingly, cluster headache patients with higher attack frequency were more likely to be triggered than those with lower attack frequency. Our patient had intermediate attack frequency. How do we treat cluster headache? There are 3 large categories: acute treatment, transitional treatment, and preventive treatment. All cluster headache patients require acute treatment to terminate attacks. Acute treatment includes oxygen at 7 to 15 liters through a non-rebreathing mask, which has level 1 American Academy of Neurology evidence and is the standard of care for acute treatment. Sumatriptan subcutaneous works to terminate attacks. Dihydroergotamine parenterally works to terminate attacks. And sumatriptan and zolmitriptan nasal sprays terminate attacks. In the United States and the United Kingdom, a non-invasive vagal nerve stimulator held over the neck and stimulating for 2 minutes in a repetitive manner terminates episodic cluster headache attacks and is approved for use. So we have triptans, ergots, oxygen, and a non-invasive neuromodulation device, which is not available in Brazil. Transitional treatment is done in order to buy time for the poor cluster patient while you are trying to get preventive treatment in place. Transitional treatment includes high-dose oral steroids for 7 to 10 days while establishing prophylaxis, or occipital nerve blocks with steroids. Some providers use high-dose melatonin, for which evidence is not very strong. So the steroids or the nerve blocks seem the best approach for managing these patients while you're getting the prevention on board. So let's move to prevention, where the big change has occurred. Preventive medications for cluster headache include galcanezumab, approved for episodic cluster headache prevention, and a variety of other medications, none of which in the United States is FDA approved, but all are used on occasion, including verapamil, anti-epilepsy drugs such as valproate or topiramate, gabapentin, lithium, the ergot methylergonovine or ergometrine, and cyproheptadine, a serotonin 2 antagonist antihistamine. The non-invasive vagal nerve stimulator, which is seen here, is also used for prevention of cluster headache, but only as an add-on on top of one of the above. And an implanted sphenopalatine ganglion stimulator, which was effective for both acute and preventive treatment of chronic cluster headache, was approved in the EU, but is not available or cleared in the US or Brazil. So these are the items that we may have access to for prevention. And in the United States, the only medication which is FDA approved for episodic cluster prevention or any cluster prevention is galcanezumab. That is why there was such excitement when the trial of galcanezumab in the prevention of episodic cluster headache was published in the New England Journal in July of last year with Peter Goadsby as the senior author. This led to this medication being the first US FDA approved treatment for cluster. I thought I'd spend a little time talking to you about the study design. These are very difficult studies to do. The galcanezumab episodic cluster trial required a screening period, and then when the patient felt that he was going into a cluster cycle, they were enrolled for first diary entry, and over 10 to 15 days, a prospective baseline which established the number of cluster attacks per day was recorded by the patient. At that point, the patients were randomized 1-to-1 to either receive galcanezumab 300 milligrams or placebo. And the primary endpoint was the number of attacks weeks 1 through 3 for galcanezumab versus placebo. These patients were then evaluated at 8 weeks, and there was a post-treatment follow-up period. So our primary endpoint is between weeks 1 to 3 in terms of number of attacks per day and per week. The total weekly cluster headache attacks was averaged across weeks 1 to 3, with a secondary endpoint of at least 50% reduction from baseline in weekly cluster headache attack frequency at week 3. And when one is looking at this study, it is useful to take that weekly number of cluster attacks and figure out how many attacks these patients were having per day. This is a summary of the number of cluster headache attacks per week in the baseline period. There were about 17 attacks per week in the baseline period, which means that the patients were having more than 3 attacks per day. And our patient would have been an example of somebody who would have been a little bit at the low end, but these were patients who were having severe cluster attacks at more than 3 times per day in their baseline. As an endpoint, you can see the drop from that was basically at least 50% for the galcanezumab group, while less than that significantly for the placebo group, with a significant p-value. And I'll show you this in several ways because it is so profound and important for our cluster patients. Remember, the baseline was a little over 17 attacks, 2 to 3 attacks per day, similar to our patient, and a drop of 8.7 attacks per week in the galcanezumab and less than 5.2 attacks for the placebo. So a drop by more than half for the galcanezumab group. And here's that secondary endpoint of the at least 50% reduction from baseline in weekly cluster headache attack frequency. And again, this was significantly different and in favor of the galcanezumab group, with over 70% having at least a 50% reduction from baseline. I summarize this in a different way in a little bit, but I want to emphasize the minimal adverse events in the study. No deaths, no serious adverse events, and very, very minimal adverse events. Injection site reaction being the most common, some sinus type symptoms a little bit more frequent in the active group. And that was about it. There was a minimal difference for a few liver tests that did not seem to play out. So again, galcanezumab was extremely well tolerated. And this summarizes my getting the arithmetic correct: 2 to 3 attacks per day, over 17 attacks per week, similar to our gentleman. And in the primary endpoint, the reduction in the placebo by about 5.2 to 12 attacks per week, but the reduction in the galcanezumab group down by 8.7 to 9 attacks per week. And the secondary endpoint, 76% for galcanezumab, 57% for placebo, in at least a 50% reduction in number of attacks by the third week. Now, there are some differences in using galcanezumab for cluster, which I want to go over with you, and I will do this in several ways to differentiate this from the migraine protocol. For galcanezumab in the study, 300 milligrams were delivered subcutaneous monthly by 3 injections of 100 milligrams across the abdomen until the cycle ends in practice. Now, I want to also point out that at the same time, a study was undertaken on galcanezumab versus placebo to prevent chronic cluster headache, and that study did not show a significant benefit for galcanezumab. And 2 studies on fremonezumab were also undertaken versus placebo to prevent episodic cluster headache, and a second one to prevent chronic cluster headache, and neither of those studies was significant versus placebo. The chronic cluster studies are easier to understand because there was only a 50% hit rate in terms of the likelihood of an attack after the intravenous CGRP in the chronic cluster patients. But we don't know why fremonezumab failed for episodic cluster. We're grateful that galcanezumab was significant versus placebo in preventing episodic cluster headache. So it's not all anti-CGRP ligand monoclonal antibodies. It's only galcanezumab, and it's not both types of cluster headache. It's only episodic cluster headache. And it's not the same dose as for migraine. And here is an example of the 2 different recommended doses. Above, you see dosages of 120 milligrams, in which at the beginning of treatment, there's a loading dose of 240 milligrams. The patient self-injects 2 consecutive subcutaneous 120 milligram injections. After that, it's 120 milligrams monthly as the maintenance dose. For cluster, it's a pre-filled syringe, not an auto-injector. Each of the pre-filled syringes is 100 milligrams, and the patient, when they go into cluster cycle, begins 300 milligrams administered as 3 injections across the abdomen, self-administered with these pre-filled syringes for each month of the cluster period. When they go into remission, they stop the galcanezumab. When they go back into a cluster cycle, they start the galcanezumab again. So quite different programs for migraine and episodic cluster headache, and very important to bear in mind. The other preventive treatments include verapamil, lithium, which requires therapeutic levels for bipolar, and this patient tried both verapamil and lithium, which did not work. Valproate, requiring therapeutic levels for seizures, and consideration for topiramate, gabapentin, or cyproheptadine. What we now do with patients is we may use these, but we start our episodic cluster patients with galcanezumab from the beginning. Returning to the case, our patient had episodic cluster headache, refractory to verapamil and to lithium prevention in the past. I prescribed galcanezumab, 300 milligrams subcutaneous, self-administered by the patient monthly across the abdomen for 3 months, which turned out to be the duration of his cycle. He then stopped it until the following year. His attack frequency dropped dramatically and rapidly, and his attack intensity was also less. His acute treatments, his as-needed treatments, which were oxygen and subcutaneous sumatriptan, dropped dramatically. He needed far less of those once he was on the galcanezumab. And he did not require any of the other medications preventively. He was able to return to work because he was not having the attacks during the day, and he has understandably been delighted with his response to treatment. He plans on going back on this set of treatments for his next cluster cycle, which we expect in the spring of 2021 if he continues in the current pattern. So in conclusion, the ICHD-3 criteria for diagnosis of episodic cluster headache now requires at least 3 months of no attacks per year. The cluster headache generator is in the ipsilateral posterior hypothalamus. The new treatments for cluster headache include galcanezumab for the preventive treatment of episodic cluster headache in the 3 100 milligram doses of 300 milligrams sub-Q across the abdomen monthly for the duration of the cycle, and the non-invasive neuromodulation approved in the US and the UK. And this is such an exciting time for our cluster patients, especially our episodic cluster patients, who have hope and effective treatment without significant adverse events in the vast majority. I cannot begin to tell you what a change it has made for the cluster patients in the US. And I assume this will happen across the world. And I thank you very much for having invited me to give this lecture.